Uh, so since couple of days, we are somewhere relaxed and feeling happy that we've seen in our northeast regions, COVID infected patients is coming down to some extent. Anyway, and in last couple of days in the pandemic era in so we never our academic is going on very nicely and fantastic way, and we are discussing so many topics and sharing uh, our skills and expertise. And so today also we are going to discuss a important and interesting subject, that is maxillofacial injury and its management. Though maxillofacial injury is not regularly practiced by all our ENT surgeons and due to multiple factors, but since still some of us is doing it very regularly and sincerely. So for this topic, Academic Council has selected the speaker, Dr. Vijay Bania, and as a moderator, Dr. Anjan Jyoti Bhuya. So Dr. Anjan Jyoti Bhuya is a leading ENT surgeon practicing in Guwahati since last 15 years. So after pursuing his master's degree from Guwahati Medical College, he was working as assistant professor in PS Medical College in Gujarat. And in that period, and he was having a very good exposure on faciomaxillary patients and did lots of surgeries. And he established a daycare ENT centers in Guwahati named Northeast ENT Institute, and catering patients from across Northeast India. And he is experienced and trained in diverse spectrum of ENT surgeries. And Dr. Anjan Jyoti Bhuya has been performing maxillofacial fracture surgery for last 15 years. Now, may I invite Dr. Anjan Jyoti Bhuya, please moderate the classroom. Anjan? Hello, Anjan.
Can you unmute, Anjan? Please unmute. Please unmute yourself.
Unmute koro Anjan.
এই সাইডত আছে সোয়া লেফট সাইডে তলত
লেফট সাইডে তলত আছে অঞ্জন
হৈছে হৈ গ'ল
শুনিছে না?
Yes, yes.
Yeah. Clearly.
Clearly শুনিছে.
Clearly.
Thank you, Dr. Apurva Da, for introducing and giving me the opportunity to moderate this special session of NEBOI academics. It's a great pleasure for me. I welcome all the NEBOI members and the special guests from other parts of India in this discussion of maxillofacial fracture. And this session will be delivered by Dr. Vijay Prakash Banik, who is a consultant and the director of Andaman ENT and Head and Neck Super Specialty Center at Siliguri. He is also a director of Dhoni Hearing and Speech Clinic and visiting consultant of Medica Hospital, Siliguri. Though the maxillofacial surgery fracture is not the common discussion in ENT forum, it has got tremendous importance in everyday practice, and as every one of us encounter trauma cases. So knowledge of management of maxillofacial fracture adds definitely to our surgical expertise or management of ENT problems. I also thank Anjanaba and Khojaba for their continuous effort in continuing with this academic event going on. So with this, I invite Dr. Vijay Prakash Banik to start his presentation, and we'll take all the questions and answers at the end of the session. And everyone are requested to put their questions in the chat box, and at the end of the session, we'll discuss it elaborately. So with this, I hand over the mic to Dr. Vijay Prakash Banik. You can start your presentation.
Bijoy?
Vijay, share, screen share koriba.
Okay, okay, ma'am. I'm just getting it. So first of all, good evening. Respected my teachers, my seniors and colleagues, and nearby Secretary Office, Dr. Apurva Sharma sir, class coordinator for GMM and Anjana ma'am, moderator sir. Thank you for giving me the opportunity to present a paper in this platform. Today I'm going to present a paper on maxillofacial fracture. Now, role of ENT surgeon in maxillofacial fracture. In my personal practice, I have found a lot of patients who comes to the OPD clinic with a deformed face, with a nasal obstruction and ear symptoms. Those patients had road traffic accident long back, and there was a severe head injury and which was attended, and there is a craniotomy scar over the skull, but the maxillofacial fractures in that time was not attended because of some factors depending upon the center and the team or the availability of the surgeon or attention of the surgeon to the maxillofacial fractures. We ENT surgeons normally get consultation, regular consultation of the trauma patient, because all these trauma patients presented with epistaxis, oral bleeding or ear bleeding in the emergency room. We also know the facial anatomy. We not regularly deals with the maxilla, also with the mandible. So we are closely associated with the maxillofacial anatomy. And our ENT surgeons, they are expertise in endoscopy nowadays. The role of endoscopy has come up in the maxillofacial fractures management of the nasal or maybe the oral cavity in the frontal on the sinuses. We ENT surgeons are the mixed surgeon in the team, so we are very closely associated with the neurosurgeons. We are also closely associated with the anesthetists. We always help in them for intubation and extubation. So there is a great role of ENT surgeons in maxillofacial fractures. So I believe the ENT surgeons should involve themselves, whoever working in the trauma center or whoever associated with the trauma hospitals. If they get the maxillofacial fracture consultation, they should go ahead of the surgical management also. And because after doing few cases, it is not that difficult that we cannot do. So before going to the definitive management, principle of the management, I personally share my experience that a good team is very, very important. If you can make a good team to manage a maxillofacial fracture, it will be very great. So this team comprises of neurosurgeon, maxillofacial surgeon, anesthetist, eye surgeon, plastic surgeon, and should have a good trauma center. Eye surgeon, plastic surgeons are very, very important for the medical legal point of view. The accident situation, the first 6 hours is very, very important. If the patient arrives hospital, the chances of survivability is much more. And we should follow the principle of advanced trauma life support, airway, breathing, circulation, disability, and exposure. And we should treat the greatest threat to the life first rather than going to the maxillofacial fractures immediately. So whenever we get an accident patient or RT patient with a facial injury, normally we should go for a clinical examination of this trauma patient. So before going to clinical examination, a little bit about the anatomical consideration. The face is divided into 3 equal parts. The upper face is above the level of the supraorbital ridge. Mid face is from the supraorbital ridge to the upper teeth, and lower face is mandible and lower teeth. Now coming to the definitive fractures, the mandible fracture. Mandible anatomical classification, symphysis, body, angle, ramus, condyle, and coronoid. The most common fractures are in the parasymphysis, angle, and followed by coronoid. So in the initial assessment, we see the jaw deformity, change of occlusion, anesthesia of lower lip, change in facial contour and mandibular arch, abnormal mandibular movements, Coleman signs, that is ecchymosis in the floor of mouth in the parasympathesis or sympathesis fractures, loose teeth, step deformity. So before treating surgical treatment of the mandibular fracture, we should know the occlusion angles classification. That is very important. The normal occlusion is that when the mesial cusp of the first molar of the maxilla sits in the groove buccal cusp of the lower, the mandibular first molar. So this is a normal occlusion. When the abnormal occlusion is that when it is anterior, when it is posterior, this is angles 2 and 3. Open bite, whenever there is mandibular fracture, the patient may not be able to close their mouth properly. So there is vertical overlap between maxillary and mandibular border. When it is anterior open bite. When it is posterior open bite. These are a few cases of parasympathesis fracture. This is preoperative bilateral parasympathesis fracture. The approaches for parasympathesis fractures may be intraoral, maybe extraoral, or maybe from the existing wound. So before going to the reduction of these, we should go for the IMF, arch bar fixation and the IMF, and go for a reduction. After proper IMF, we should reduce the fracture fragments and internal fixation with the plate in screw. These are the photographs of the postoperative. This is the rubber band where we do a IMF like this after 2-3 days and keep for the 4 to 6 weeks. And this is the result of the anterior occlusion also, and the posteriorly we are having a good occlusion the both sides. This is the case of the angle fracture, where the angle fracture may be combined with the parasympathesis fracture or maybe associated with the condyle fracture. So this is the picture of case of the bilateral angle fracture. So we approach angle from the intraoral approach, also extraoral approach. Here we are showing the external approach, the submandibular approach, 2 centimeter below the submandibular margin. We give an incision, go through the platysma, cut the masseter muscle, reach the fracture site, reduce the fracture, and put a 2 to 2.5 mm plate, big plate, and fix it. And these are the fractures of the condyle. So condyle fractures, all condyle fracture doesn't require open reduction and internal fixation. We see the what kind of condyle fracture is there. There may be intracapsular fracture, maybe extracapsular fractures, maybe low condyle fractures. Those condyle fractures which is having a displacement and gross deformity. So in those fractures and the low condyles, we approach the condylar fractures by the surgical treatment. Otherwise, we go for the IMF. Sometimes we get bilateral high condyle also. So in those cases, the internal IMF is sufficient. So there is this is the picture showing a margin of the mandible. We normally go through the transparotid approach. There are other approaches for the condyle also, retromandibular approach and the preauricular approach. This is the picture showing a plate fixed in the condyle, the low condyle. Tips of fixation, normally we use 2 mm system plate. The plate is 6 mm wide, 0.10 mm thick, and with a standardized hole differences, screw size is 6 to 8 mm. Adapt the plate properly. 1.5 mm drill bit is used. Drill bit should be perpendicular to the plate. Repeated insertion of the drill bit should be avoided, and continuous watering during drilling is important, and single give up should be appreciated. These are the various types of the screws we are seeing. These are the mandibular screw we use, 2.5 mm or 2 mm. These are the beads, the 1.5 mm ranging from 2 mm. These are the orbital plates. These are L plates, Y plate, X plates. And these are the various screws for the varieties of the plates, like 1.5 mm, 2 mm, 2.5 mm, ranging from 6 to 8 mm normally we use. There are some emergency screws are also there. Whenever the previous screw is loose, then we can put an emergency screw over there. Now coming to the midfacial fracture, this is the region which is responsible for our sense of smell, mastication, vision, and speech. René Fort in 1901, French surgeon, who described midfacial fracture and divided into Lefort fracture. Lefort 1 fracture, this is a low-level fracture with a horizontal fracture above the level of the nasal floor, maxillary sinus, and pterygoid plate. Lefort 2 fracture, the fracture through zygomatically-maxillary suture, inferior orbital rim, and nasal bridge. So this is a pyramidal fracture. And Leaford 3 fracture is a craniofacial disjunction. This fracture goes through the zygomatic arch, medial and lateral orbital wall, and the frontonasal suture, and crossing the opposite sides. So it's a total disjunction of the face from the skull base. There are another classification also. I'm skipping these slides. And normally we don't get classical Leaford fractures. All fractures normally we get the mixed type of fractures. So after getting a midface fracture, we should look for important things like damage to the nerves, CSF leak, sometimes infraorbital nerves are damaged, optic nerves are damaged, bilateral circumorbital ecchymosis and swelling, that is called raccoon's eye sign, diplopia, anophthalmos, loss of vision. These are the very, very important pictures we should have a look before we land up in the surgery. Sometimes we get very life-threatening hemorrhages in the midfacial fractures. We have encountered a lot of cases like that. We do know postnasal pack is bleeding from the greater palatal vessels. Before going to the surgical management of the mid-phase, we should understand the vertical buttresses and the horizontal buttresses. These buttresses are very, very important because these buttresses, they share the load of the facial bone. So this is nasal frontal buttress, zygomatic buttress, pterygomaxillary buttress, and also the nasoethmoid buttresses. Horizontal buttresses are superior buttresses like frontal bar, inferior orbital rim, maxillary alveolus and the palate, maxillary alveolus and palate and the mandible, and lateral and medial pterygoid plate. Goal of surgery is to maintain the integrity of the face and patency of the nose, orbit, and vision, eye movements. These are the main goal. Previously, these fractures were fixed with interosseous wiring and also the external appliances. Nowadays, we go for the open reduction in internal fixation by mini plates and micro plates and screws. These are the photographs of the previously when hollow frame and Wasman's maxillary splints. What are the approaches for the midfacial fractures? For the pterygomaxillary or maxillary nasomaxillary work, we go for the gingival-labial sulcus incision. This is the sublabial incision. Sometimes if it is a bilateral fracture, we combine this incision from right side to left side. For orbital fractures or infraorbital rim fractures, these they are the options for subciliary, infraorbital, transconjunctival. Normally, we try these two incision for the infraorbital fractures. Lateral brow fractures for the frontozygomatic suture, coronal approach for frontal fractures, and if there is existing wounds in those areas, normally we extend the wound and try to go through those wounds. Hayton-Williamson forceps is very important in midfacial fracture to reposition the maxilla, pull out, and for the proper occlusion, and also for the palatal fracture, reduction of the palatal fracture. Classically, these Leaford fractures should be managed according to the type of the fracture, but normally we get mixed fractures. So our principle of surgery is that we plan the surgical treatment depending upon the type of the fracture or extent of the fracture. Sometimes Leaford is combined with Leaford 2, or sometimes Leaford 3, we have a panfacial fracture. So the management of these fractures, we go from above to down. So normally we first fix the stable component frontozygomatic suture, and after that we go for the pterygomaxillary suture and the nasomaxillary or frontonasal, depending upon the type of the fractures. Now there are some conditions where we don't go for the open reductions. We should we choose for the close reduction, like non-displaced favorable fractures, when the fractures are very, very pieces comminuted, when there is extensive loss of soft tissue overlaying the fractures, edentulous mandible fractures, the fractures in the children's, which is in the developing dentition without any displacement, coronoid fractures, condylar fractures, a few condylar fractures, the intracapsular or small undisplaced fractures, we don't go for the open reduction, rather we go for the closed reduction or IMF or ARDVA. Indications for open reductions like displaced favorable, unfavorable fractures, edentulous mandible with severe displacement, when the treatment is delay and intraposition of the soft tissue is there. If there is a systemic contraindication for IMF, and if there is a malunion, definitely we go for the delayed cases. If there is, we need to do a surgery, we perform the osteotomy and we again reduce and plate and fix it. There are some advantages of the open reduction, like it is accurate reduction and fixation of the fractures by the direct visualization, better bone healing, early return to the normal jaw function, normal nutrition, no weight loss, But there is weight loss if we go for the IMF. Obviously, we have seen the patient losing weight loss 4 to 5 kg after four weeks of the IMF. Patient can maintain oral hygiene is early return to the work. There are some disadvantages like required surgical exposure, GA expensive compared to IMF, it's difficult. Sometimes plate has to be removed, like if there is infection or some foreign body reaction, the foreign body is left in the tissues and scarring. Now, there are different techniques of the dental wiring, the interdental wirings like glimmer technique, eyelet techniques. Normally, we go for the arch bar, and the eyelet for the fixation of the IMF. Bridal wirings. I'll just go ahead. The arch bar, normally we go for the arch bar and intermaxillary fixation. This is the pictures of the orbital fractures, the infraorbital fractures, which are reduced, and in orbital plate is placed on this. This is a curvilinear plate which can be adapted in those places. Now about the nasal bone fractures, the nasal bone fracture, the most common fractures because of this projecting structure in the face. So normally the impact normally goes to the nasal bone. So it's the most common fractures. The nasal bone fractures may be angulated, may be depressed. On the angulated fractures, the blow is from the lateral side, depressed fractures, the frontal blow. Sometimes it may be simple fractures, simple unilateral fractures. Sometimes it may be bilateral fractures. Sometimes it may be comminuted fractures. And if there is a frontal block fractures, there is an open book deformity. Sometimes it may be associated with septal hematoma, and in severe cases, like it may be associated with an NOE fracture, naso-orbitoethmoid fractures, the mid-face fractures. Few cases when the angulated fracture, lateral deviation, if arrives in early hours, then we can go for a manipulation of the nasal bone fractures under a very easy procedure. Otherwise, if the fracture is comminuted and having a septal fracture, we need to go for a GA. So we go for a close reduction and with or without septoplasty as per the requirement of the surgery. In the NOE fractures, the nasal stability we do by the open incision or the pre-existing incision or the infraorbital incision, we extend up to the nasal region where we fix the nasomaxillary frontal process of the maxilla and frontonasal also. These are the photographs of the nasal bone fractures. This is the S forceps, so with the for septal elevation, and this is the Wilson forceps, so for the close reduction with the outward movement and inward movement, disimpaction and reduction. Naso-orbital fractures, this is a central midface fractures where this medial wall of the orbit may be unilateral, may be bilateral, and mostly it is bilateral. So nasal bone and medial orbital wall and ethmoid is fractures. The raccoon sign is a very classical for this. This is the treatment plan. This is very comminuted fractures. We doesn't need to fix all the bones, all the pieces of the bones. Normally, we put on inverted Y plate for the frontonasal bridge, nasomaxillary region, and frontal process of maxilla and infraorbital rim. It works. And medially, sometimes we reduce the medial wall of the orbit. Zygoma fracture may be isolated fracture, may be associated with the ZMC fracture. So Gillies elevation is very nice. So temporal incision, we give a temporal incision. We go through the temporalis fossa and put the Gillies elevator under the temporalis fossa, reach the zygomatic arch, which does that when we reach the zygomatic arch, go medially and we just elevate it. ZMC fracture is a tripod fracture. It is not a tripod fracture. There is a fracture over the zygomatic of frontal suture and pterygomaxillary suture and also the zygomatic arch. So these fractures normally fixed by the MZ fixation, pterygomaxillary fixation, and elevation of the zygoma. There is the fixation showing, and there has to be the opening of the mouth should be like this. These are the fixation where we see the plate over here, frontozygomatic, infraorbital, pterygomaxillary. So buttress fixation is very, very important in midfacial fractures where we get a good figurement post-operatively, and also the force which is applied for the chewing is normally transferred to these buttresses, so they get strengthened. So this is supraorbital, this is lateral brow incision for the frontozygomatic fixation. This is infraorbital for the infraorbital rim fixation, pterygomaxillary fixation. Sometimes we get the palatal fracture, which displays palatal fractures. Normally, we go for the intermolar wiring. We can leave it for at least 2 weeks, then we can remove it. Otherwise, we can go for a transmucosal screw, platen screw, which we can leave for 10 to 14 days, and we can remove it. It normally heals. There are various incisions for the infraorbital approaches, subciliary incision, postoperative picture, and this is the infraorbital incision. Sometimes we encounter only dento-alveolar fractures. So this is separately like managed, like dento-alveolar fractures. We normally go for the simple arch bar with debridement of the lesion and wound and removal of the tooth fragments or the bony fragments. Frontal fractures maybe it is divided into anterior table fracture, posterior table fracture. Sometimes it may be associated with CSF leak if there is a anterior skull base fracture. So these fractures during neurosurgical surgery, we normally elevate the anterior table and sometimes we leave it, or sometimes we fix with the small mini plates. Or sometimes if there is a loss of the frontal bone or we have to remove this frontal bone, we put obliterate with the galioaponeurosis, fascia aponeurosis, and put a titanium membrane over there. Now coming to pen facial fracture, whenever pen facial fracture arrives, this is the life-threatening condition for the patient. So we ENT surgeons, we must first attend the patient, because other specialty, they actually afraid of the opening the mouth for intubation also, and this patient presented with severe bleeding also and breathing difficulties. So we normally we do the cleaning of the oral cavity, remove the loose teeth, the bone fragments, intubate the patient, and after initial assessment of the head injury and other polytrauma injury, we go for the tracheostomy. These fractures would be, this kind of fractures we need to do a tracheostomy first, because this is important, is the airway problem is always there. There are a few cases where there is no severe head injury or patient doesn't require ventilation, and we maxillofacial surgical team, we think that we need a job in the nasal cavity, nasal bone, and also we need a IMF, a good IMF for the reduction of the mandible and things. So we can go for a separate intubation, like submental intubation. We do normally anesthesiologists, they do the oral intubation. We put an incision over the submental region and medial to the mylohyoid muscle, and through the lingual border of the mandible, we make a tunnel in the sublingual space, and we pull out the cuff and the tube through this. And after the finishing of the surgery, we normally extubate. And after 2-3 days, we do the IMA for these patients, these kind of patients. So final outcome, we should have a good nasal patency, Angles 1 occlusion, good opening of the mouth. This handsome guy had panfacial fracture. After 6 months, he's having this. There are few complications of the maxillofacial fracture management: nasal residual deformity, malocclusion non-union, hypertrophic scars, wound infection, neurological deficits. Little bit about the pediatric facial fracture. We don't attend all pediatric facial fracture because they are the developing dentition. If they are depends upon the type of the fracture, displacement, and the age of the child. So if it is within 2 years, normally we do a splint. The splint is made according to their dentition, the lower jaw structures, and this is fixed with the circummandibular wires, which can be removed after 2 weeks. Those fractures which is comminuted and displaced, normally we go for the ORIF in those cases, but we remove, normally these plates should be removed at the end of 3 months. Now coming to conclusion, an aesthetic face, satisfactory nasal patency, a good vision, satisfactory occlusion with wide opening of mouth are the goal of management of maxillofacial injury. So we team should have a accurate and complete lesion evaluation and planning for the treatment, and medical legally we should inform the patient the concerns, what are the consequences, because nowadays, previously they were not aware of a lot of attention of the maxillofacial fracture, because these patients normally they attend the neurosciences centers where they are having head injuries or polytrauma injuries. But nowadays people are getting aware of a lot of facial like aesthetic values. So I acknowledge our team members, Dr. Sumit Agarwal, he's a maxillofacial surgeon. So initially we were separately doing, but nowadays we are doing together. And this is like giving us a value of surgery that the time is also less, we get a good result. And most of the time in the nasoorbital fractures, we do a nasal endoscopy. That is routinely we see the collapse of the medial orbital wall or the lamina papricia fractures. We remove the fragments. And also we address the nasal septum. We see those nasal septum fractures are there. We do a septoplasty, we repair the mucosa, and we get a good nasal patency in those cases. We have Dr. Rafid Debarma, anesthetist. So we normally work in the ENT, and anesthetists have the same area. So most of the time we help him, and they are the cooperative. He is the main person between coordinating with the neurosurgeon and ENT and maxillofacial surgeon, and also the patient party. Dr. P.D. Varali is a neurosurgeon over here, and he always cooperate with us, normally give the consultation and allow us to do maxillofacial surgery wherever possible at the same sitting. We normally don't delay the surgery. Why? Because if the patient is having same like severe head injury and can be managed by the neurosurgical procedures, the neurosurgeon decide that which patient is going to survive or which patient may not, or maybe may not return. So those cases, they call us for the surgical procedure, the same sitting. It saves the patient money also, time also. And whenever the patient come back from the coma, they have got all result, total trauma care. Dr. Samuel Saha, eye surgeons, we normally get a preoperative consultation wherever we required, and also intraoperative intervention also. Dr. Sohaib Akhtar is plastic surgeon over here. Whenever we see the maxillofacial fracture with having a very major soft tissue loss, or the eyelid also, or the major soft tissue loss, so we give a consultation of the plastic surgeon so that we are in the safe hand. And one thing I left in the condyle fracture, during condyle fracture, I have personally experienced the ear bleeding. But there was ear bleeding because of the condyle hit the external auditory canal, the bony external auditory canal. So there is also displacement of the bony external auditory canal. At the same setting, we look into the ear canal, we just reposition or reduce the bony external canal, put a pad that always give a good, like the future conductive hearing loss is not there. Thank you very much.
Thank you, Dr. Vijay. Can you hear me?
Yes, sir.
Okay. Thank you, Dr. Vijay. It's for your elaborate discussion of maxillofacial fracture. Within a very short period of time, you have elaborated and touched all parts of the maxillofacial fracture. Though it is a very vast subject,
Yes, sir.
we have a lot of questions in the chat box. I will be asking one by one. So let's see. May I start the question and answer session?
Yes, sir.
Okay. The first question is from Dr. Setabrat Pukon sir. How the Leapford made the classification? How the Leapford made classification? Means
Leaford classification.
means in what basis? Maybe he is asking in what basis the Leapford made the classification. Hello, sir. Can you hear me, sir? Pukon sir?
Yes, yes, I can hear him.
Yeah. So your question is how the Leapford made the classification.
Actually, I want the history. The history is
Okay.
really interesting. Therefore, I'm asking.
Leaford inflicted facial trauma on 35 individual cadavers, after which
Very
he
nice.
examined
Yes.
skeletal structures for patterns of the injury.
He actually violated the rule, and he took 35 cadavers, and his injury with the hammer, with
Yes,
the
sir.
stick,
Hmm.
and also with the ball, hard ball, and
Yes,
made
sir.
some fracture on different direction.
Okay.
After that, he made the skull we boiled the skull and examine the fractures, and from that he has discovered the different type of fractures. It's really, really interesting. Therefore, I'm asking.
Yes,
No
sir.
other way. Thank you.
Yes,
Yep.
sir.
But the Leapford classification, it's a combined type of fracture. Whenever we see in the rotary accident or like that, so it's a Leapford 1 or 2, 1, 3, all the combined fracture.
It's a type of 1, 2, 3. Rightly you have said it is a horizontal type. One is a pyramidal type. One is a complete separation from the skull base. The
Yes,
where
sir.
CSF rhinorrhea is the most complication. You are right. Thank
So
you.
Nowadays, road traffic
different
accident are.
importance actually in
Yes,
type.
road traffic is the most common.
Yeah.
Vijay, can you raise your volume little bit?
Yes, Vijay, but less.
So
How
next
many? It's
question
okay.
is how IMF is applied in mandible and maxilla.
Pardon, sir.
How IMF is applied in mandible and maxilla.
First, we do a arch bar fixation. We do a arch bar wiring. When the arch bar wiring is fixed, initially during surgery, we put a loop wire to do a IMF in the molar region, in the maxillary molar region and central region, and also the premolar region. And after surgery is finished, normally we remove the this one wires And after 2-3 days, when each patient is more stable and swelling is subsided, we put rubber band. So rubber band, it is like from as a inverted loop shape from lower to upper to lower and lower to this one crisscross. And this we keep for 4 to 6 weeks normally, depending upon the severity of
So
the disease.
intubation is always it's a nasal intubation. Yeah?
In those cases where the nasal job is not required, so we go for the nasal intubation. Otherwise, if nasal panfacial fracture or something, we normally prefer, nowadays we most of the cases prefer submental intubation.
Submental. Yeah. Okay. So the third next question is it right, sir? Pukon, sir?
Right.
Okay.
I'm
So the
because
IMF
he no
usually is,
many people may not IMF because he repeatedly mentioned in his
it's
presentation IMF, because what is IMF actually, this subject is not common for ENT surgeons, those who have not been in trauma center or not accustomed with this all facial surgeons. That for this ENT surgeons, many people are attending here, but many people not do IMF. Therefore I'm asking actually.
it's a maxillary fixation. That means we keep the upper alveolus and lower alveolus tooth in a occluded position.
Yes.
So to perform to keep it in that position, so we need to fix it
Yes.
by some wearing. So wearing is done by arch bar as seen in the picture. So arch bar in the upper alveolus, arch bar in the lower alveolus, and pull both the arch bar through the rubber band. This is one of the way. And second way is we can put some loops in the different positions. Yeah, this is the loops in different positions, and these loops are tightened after the surgery or during the surgery to keep the teeth in occluded position. So occlusion is the primary goal in doing this surgical result.
Yes. But this Clovis is a scout knot, no? In our scout days, in our college school days, we know the Clovis knots, knot.
Yes.
Yes, sir.
So usually that it's called a dental wear. Dental wear, this size 24 or 20. What size you use? 26.
26 SS.
Yes, 26 SS wear.
Hmm.
So mostly the 26 SS wears are used for this fixation purposes.
Okay.
So the next question is from Dr. Mohan. He has asked, is the comminuted and compound fracture of the nose can in comminuted and compound fracture of the nose, can you highlight about tripod suspension and stabilization technique? Maybe he's asking about how it's in the Lapo tree fracture, how you do the suspension, it's like that.
Yeah, it doesn't have any photograph over here, but when there is a comminuted fractures, we have inverted Y plate. So if there is some existing wound also, or if not, then we can have a bro incision over here, and we can fix this nose one, this one major one. So we can't put all the pieces over there, and we find out which is the biggest piece of the lateral nasal bone with the infraorbital or maxillary frontal process of maxilla. So we normally fix this, and we put a bridge elevation and put a nasal pad, septal correction, and also put a nasal pad and this printing, and that's much.
Yeah, this is very difficult because
It is very
the nasal
difficult.
bone is
Most of the time we get
very
residual
thin.
deform.
So putting a screw in the nasal bone is very difficult.
Very difficult. So that's why we find out which is the area where we can put basically. And once we use a glue, tissue glue in the fragmented nasal bone fractures, we had one complication after putting the glue. The fracture was aligned, but there was some sinus and some foreign body reaction was that, and it took around 2 weeks time to heal it up by regular dressing and all these things.
Vijay,
Yes, sir.
acha, ye Dr. Sujoy Joshi from Gujarat, he
Yes, sir.
used to do this technique, a stabilization technique, that tripod
Yes.
suspension and stabilization technique.
Yes, sir.
So now, what he used to do, he used to put some external fixator through the septum of the nose.
Yes, sir.
And putting, fixing it from above. But I saw him once doing
Yes,
this fracture, comminuted fracture. man gives a very good result. Very good result. So that is why actually I want to know your experience regarding this.
We doesn't have so much of experience in the tripod.
Yeah. So this type of competitive fixture usually fixing with through the septum. Maybe I am not very sure how they do it. So I think
Vijay,
Yes, sir.
Rakesh Yadav in his presentation AOI, he has not shown that tripod type. No, he has not shown. I think in the
No,
paper.
no, sir. No, sir.
Yes,
He skipped two things. This
the
one,
one. Yes,
nasal isolated fractures, and this one, submental intubation.
some maintenance.
Yes.
Correct.
But they are doing a lot of endoscopic inclusion of the maxillary facial, like the condylar fixation. They are making an intraoral incision and making optical tunnel and reach the condyle. They pull the condyle through the optical tunnel to the reduction position, and trans buckle they make a screw system like that. So
Yes,
this is
he
not
has shown
impossible.
so much approach,
Yes,
so
sir.
much incision via endoscope. It's difficult to follow. Also, I don't know.
Yes, sir.
You may follow, but we cannot follow it. Thank you.
Yes, sir. Thank you, sir.
okay. So again, the Fukan sir has asked is the diagnosis how clinical examination and what image are applied for. How is the diagnosis? Means how you diagnose the fractures and what are the different modalities and how.
In the investigation, radiological investigation, clinically, so obviously we can go through the facial examination stepwise. Like if patient comes with a facial maxillary trauma, we should look from the frontal to bottom. So we first see the frontal supraorbital ridge, and we check the orbit. We see the subconjunctival hemorrhages. We see the position of the orbit eyeball, and also we see the any swelling or circumorbital swelling of the orbit. We also check the telecanthus distance from the one medial orbit to other side. And we also see the external lacerations. What are the lacerations over the eyelid? Then again, go to the nasal breeze. Sometimes we get crepitus over there in the nasal breeze, and also deviation of the nasal breeze or depletion of the nasal breeze. We check a step deformity of the infraorbital region. We may get a step deformity in infraorbital region after a clinical examination. We see the dentition. What are the dental structures over there? The loss of the teeth or gap, whatever. And then we put a hand over here, the maxilla, upper maxilla, and we move it. If it is like whole upper jaw is movable, it is like it is very loosely movable, it is likely for one fracture. We put a one finger over here and move the jaw lower, upper jaw. If we feel a movement over here, it may be for two type of fracture. If there is FZ is involved, then we can put a lateral finger over the lateral orbital wall, and we can feel a movement. And if there is a disjunction, we can feel a movement over here. So these are the how we can classify clinically. And after the mandibular fractures, I have already explained. Radiologically, normally we prefer CT scan of the face with 3D reconstruction. That is important. And sometimes for simple mandible fracture, the people come with OPG also, orthopentogram, that is also sufficient. But to see exact anatomical location and displacement or angulation of the fracture, CT scan of the face with 3D reconstruction is very, very important.
Okay. So if I can add one point here is the eye movement is a very important
Eye movement is
observation.
important.
Yeah. So if there is any muscle entrapment is there in the fracture fragments, so that will indicate that will show us. Look. And secondly, if there is any intrusion of the eyeball or if there is some blowout fracture and that head prolapse or anything like that, it should be observed before the surgery.
Yes, sir.
And moreover, the vision is an utmost importance before doing the surgery, just before putting the patient in surgery. Some patients with head injury, they may not be too conscious to uh, give the eyesight. So in that sense, the eye surgeon has got importance, so that they can actually let us know whether there is any optic trauma or orbital trauma or not.
Yes, sir.
So, yeah,
The documentation is very, very important, sir.
very important. And how you fix if there is some blowout fracture, means infraorbital fracture blowout, and how you do it? Do you do some
So in infraorbital fracture, most of the time we get the floor of the orbit is like fractured and collapsed into the maxillary sinus. And we have found that we anterior fracture also. So normally we see what kind of, like, if the bone is bigger pieces of the bone, we can deposit it. We first reduce the pad of fat over there in the orbit, and also reduce this plate of fractures. And normally it goes on. And in
do,
some
do you
cases there is a
enforce?
large, yeah, we large gap. We put titanium mesh over there. The orbital meshes are available. So we resize the meshes accordingly. We raise the flap over the peristral flap over here, reduce the fat in the orbit, and we put a mesh over there and put a screw over here and there, the two side. That is sufficient.
Yes, and I will take another question here. How to decide the correction in infraorbital fracture? How to decide which fracture to be corrected? Infraorbital fracture. It's like that.
Yes, sir.
All, yeah, all fractures should not be corrected.
No, no, no. Normally, we see after fixing a fronto zygomatic suture, if there is a multiple or complex fracture, and after fixing the addressing the pterygomaxillary buttresses, we normally palpate the infraorbital rim. If there is no significant step deformity, we leave it behind legs. If we feel like that there is a job of the nasomaxillary also, there are multiple site of fractures where you need to address the frontal process of maxilla also, and there is a step deformity. Normally you go for the digital fixation like this. So
Yeah.
in these cases
So
we
it's mostly two reason of doing this kind of surgery. Number one is if there is restricted eye movement,
yes sir,
and number two is the cosmesis.
yes sir,
If there
No,
is depression of the malterminus, then we will have to do it. Or if there is uh, restriction of eye movement, then you will have to do it.
yes,
Vijay,
yes sir,
I've asked the question because many cases also come to us with the 3D imaging and they say whether to do operation because some physiomaxillary surgeon want to operate.
Hmm.
Actually, it's difficult for me to take the decision. Then as I know, there only anophthalmos and diplopia is if they is present, then
Yeah,
you should go
that are
for the
clear.
approach, the operation. Because I advise to wait for some time. If there is no diplopia and no anophthalmos, you don't do the operation. Many cases get very good result, but the facial surgeon want to operate, even plastic surgeon also. But I don't think that it is correct or I don't know because therefore I'm putting the question here.
Yes, sir.
What do you think?
If the zygoma is depressed, then we'll have to reduce it
No,
and
zygoma is a different, but if it is a diplopia or anophthalma, this is the only indication
yeah, yeah.
for doing the orbital flow repair.
Mm-hmm. Yes, yes, right, sir. Right.
I think
Orbit
so,
only
yes.
we address whenever there is a major step deformity, or if the orbital function is like that, or
Yes,
if the fracture fragment is like compressing and having a orbital movement disturbance.
yes. Because the step deformity is not much. Then I
We
think
don't do, we
no
don't.
need to operation.
No, no
That's
need to.
right. Thank
Only
you.
thing we need to think of that these buttresses are
Yes,
very heavy buttresses, because I have practically encountered 2 months old fracture that can't even able to chew mutton or chicken or
yes.
hard chewing. Why? Because these buttresses, if it is displaced, they heals very badly and they
Uh,
give a pain over there. So this is pterygomaxillary buttress, and we know that jaw has got very large number of force, the large force. We can bite or pulling. These buttresses get hit. So we should take care of these buttresses, and others are like cosmetic and nasal patency, nasal buttresses, these pyramid buttresses. If we leave behind also after doing these two buttresses, this thing will be healed up.
if there is no fracture in the pterygoid process,
Yes, sir.
if there is fracture, then pulling up by the pterygoid muscles, I think the correction is needed by this fixing, no?
Yes, sir.
Because for the correction of the occlusion.
Do you always do the fixation in this type of cases, or do you do some suspension in this? Frontozygomatic, fronto-maxillary suspension or zygomatic-maxillary suspension also done in some instances in this type of fractures.
So frontozygomatic, these buttress normally we address if it
Fronto-maxillary
is,
suspension.
yeah, sir, with a plate and screw only, sir.
No, it's a suspension wear that can be put from the frontal bone to the maxilla. This is suspension wear that can be, this maxilla can be suspended into
suspended. That can be suspended.
Suspended by wear.
We have not done, sir.
Okay. So this type of fracture, with craniofacial disjunction and all, this type of fractures can be suspended. Means it can be suspended to the frontal bone, or it can be suspended if there is no fracture in the frontal process of the zygoma. Then we can suspend it to the zygoma also. If there is fracture in the frontal process, that it can be suspended to frontal zygomatic process of the frontal bone.
Okay, sir.
It can also be done. Yeah.
Yes.
And next question is the incidence of CSF rhinorrhea in NOE complex fracture. Nasolateral complex fracture. CSF rhinorrhea. How many cases you have seen with CSF rhinorrhea?
We encountered very oftenly, sir, CSF rhinorrhea, but these rhinorrheas, they stop spontaneously. Yes. Very rarely this is long-term or traumatic rhinorrheas stops spontaneously, and most of these kind of upper face or central middle face fractures, they are associated with the head injuries, severe head injury. So we have seen neurosurgeon when we are associating with them. We have seen they do the anterior frontal craniotomy and go to the base, remove the crista, and they see the dural tear over there. And that can be managed very easily with the dural graft and putting the another graft to this give a support. So these are common.
Endoscopically also it's possible. Endoscopic CSF leak. It can also is also possible. A few days back, I got a case of fracture, ethmoid fracture with the frontal bone fracture. It's in the posterior table fracture, and it was CSF rhino. It was 3 months old, so ultimately we had to do it. But we tried to do it endoscopically. Ultimately, it was a little bit difficult, but we could manage it with the frontal table fracture, posterior table fracture.
Okay.
So it is possible. It can be done. And how will you manage a case of displaced neck of condyle fracture with displaced ZMC? How you plan it?
Displaced ZMC.
Displaced ZMC and condyle fracture. Displaced condyle fracture.
Okay. The ZMC fractures are normally we address. We have to address. And because if the condyle is also fractures, the mouth opening is very restricted. So because of they hit the zygoma is also fractured, and condyle is also fractures. The coronary fracture, coronary goes and this one, like if there is a fracture over here, this coronary goes and hit the zygoma. And if the zygoma is also fractured and there is a tripod fracture, they disturb in the mouth opening. So this mouth opening is very less. So we normally we do address the ZMC fracture, and we see what is the status of the condyle fracture. And after fixing the ZMC fractures, we open the mouth and we see whether the mouth opening is normal or not. And we, depending upon the level of the condylar fractures, in some incidences we had to remove the condyle from that fossa for thinking that future ankylosis and all those things. Otherwise, we don't address the condyle in that time. If the lower condyle is there, we normally put a plate over there through the transparotid or try to intraoral approaches.
So in isolated condyle fracture, yes.
Dr. Gautam Khan has something to share. Gautam, please unmute yourself.
Thank you, Anjana. Actually, we are actually discussing much more serious things than what I do. But I wanted to share basically that a long time back in 96 probably, Kudus sir and I had actually at that time mini plates and all those things were not being practiced in facial maxillary surgery, was also not so popular. So we had a patient with type 3 nasal fracture with the whole nasal bones going in, telescoping into the ethmoidal complex. So what we did is actually we and there was glabular fracture as well. So we lifted it all up and we used to put the buttons of the blazers and pass steel wires through and through the nose and keep it in place. And we held the wires on uh, a self-made frame, which was with a stick, with a rod, which we designed ourselves by looking into the books, and we kept it in place, and we kept that frame in place for about 3 weeks or so. Actually, we published it in our local journal at that time. Just sharing that we went through that phase, and now you are talking about much more delicate and much more work with much more finesse. Thank you.
Thanks for sharing your experience to that. It's quite interesting.
Actually, the thing is Gautama that is improvised by Datta. He got the idea that I still remember. He has presented, he has published in this in our journal also. Very nice impression. That thing, that question is asked by Mohan also about the Gujarat. You have asked there about the fixation externally, it is pendle fixation. The nice improvisation at that time, 1996. I don't remember the year, but still I remember the photo. Thank you.
Can I just put in
Vijay.
a word here? Go to
Vijay.
some rejoinder.
Vijay,
Yes, sir. Ahmed.
just regarding the question about that displaced neck condyle with fracture with zygomatical complex fracture, regarding that,
Yes, sir.
now thing is that what about the occlusion? Because you have to give the importance to the occlusion.
Yes,
so if the occlusion is adherence, then you have always give priority to the condyle correction.
Yes, sir.
Yes. Now, normally, if lateral displacement is there, then you go for open procedure. If medial displaced, then you go for a conservative procedure.
IMF, yes, sir.
Now, thing is that if occlusion can be established easily, occlusion can be established in medial part of the fracture. Occlusion can be established without any trouble. Then patient can be treated conservatively. But if it is on the lateral position, you have to go for ORF
Yes,
if occlusion is totally dearranged.
Yes, sir.
Now, again, you have to put fixation to the intermaxillary fixation. Along with that, also you need to put it intermaxillary fixation 3 to 4 weeks also.
Yes, sir.
Achha, my point is that what about the early mobilization?
Early mobilization of IMF.
Yeah, early
So,
mobilization, yes.
So normally, if condyle is involved and we are thinking of condyle, so normally we keep the IMF for at least for 4 weeks. It is why, because these are displaced also medially, and we need to heal up the ZMC fracture, and we need to have a good opening. And later on also we remove the IMF. We have seen there is a decreased opening and this one movement of this jaw. So it is better to early mobilization of the condyle to avoid the ankylosis and also the muscular this spasm also, sir.
Okay, you advise early mobilization as early as about what weeks you usually advise?
Normally 3 to 4 weeks, after 3 to 4 weeks.
Okay. Thank you.
So,
Anjan,
Yeah.
hello, Anjan, Ahmed sir,
Kudus
Kudus Ahmed sir sharing
Kudus
something.
Ahmed, yeah.
Kudus Ahmed sir sharing something. Anjan,
Yes,
please
yes.
invite Anjan. Yeah.
That was in 1996 when we had to do what is often referred to as the Great Indian Jugaad. We didn't have anything on our hands, so we gave the idea that we need something to suspend this elevated fractured fragments to Dotto, who is the manager of Nightingale Hospital. So Dotto is a great jugari. So he disappeared for some time and came back with that frame. And that frame did wonders to holding up the displaced fragments, raised fragments. So it is just one of those things that if you don't have anything, suddenly land up with something that you don't have, you can think of jugaad, what is known as jugaad.
Yes, sir.
So that was that is what can be referred to as a great Indian jugaad. There was an article in the Digest regarding the great Indian jugaad.
That is true.
Yes. In respect to the condyle fracture, I want to add one or two points. So in pediatrics age group with condylar fracture, it's not very uncommon. So only the condyle fracture is there in the pediatric age group and mouth opening is not mouth opening is not too close. So we can put the patient in conservative way. Means we don't do IMF. We don't do anything. Just put the patient on some analgesic and ask him to open the mouth and close, mobilize the joint, and it forms a pseudo joint. Actually, the pseudo joint helps, and just below the flexor fragment, there is a formation of the second joint. So this acts perfectly, and there is no residual deficit. And in adult, if there is condyle fracture only, and there is no other mandibular fracture, and there is opening difficulties and malocclusion, then we can put the patient on IMF only without doing any pinning in the flexor fragment. So that can also be done.
Yes.
Sometimes the condyles, removal of condyles also helps in this regard. So, and do you hello?
Yes, sir.
Is it right? So do you
Yes,
have
sir.
any?
Yes. No, sir. You're absolutely right.
Yes. So any other question? Anyone want to ask anything?
Sir, I want to tell one thing.
Yes.
Hello.
Yes, sir.
Am I audible?
Yes, sir.
Yes, sir.
Just I had the experience of bilateral TMJ ankylosis. A patient was brought to us and history of mandibular fracture, probably maybe in the condyle itself. But then there was when the patient presented to us, the patient had total trismus. And there was bilateral TMJ ankylosis. That was osseous ankylosis.
Yes, sir.
Okay.
Am I clear?
Yes, sir.
Now then, what was done is TMJ in the TMJ area, because the definite area is not there because the whole thing is a bone now. The segment of the bone was excised to create the joint space. It was done in the gap of 2 weeks. It was done on both sides.
Yes, sir.
And then after that, the patient did not have any problem of trismus.
It's a
I don't know how they explain it because we know the lateral pterygoid, medial pterygoid is attached on the inner surface of the angle, whereas
you're not audible, sir.
He got disconnected. There were a few questions. It's not visible in your screen, Anjan. There are 2 questions. I'll read it out.
Please,
Importance of 3D CT in midfacial fracture, and second is incidence of anterior ethmoidal artery injury.
Yes. Yeah.
We encounter very severe epistaxis and nasopharyngeal bleeding, posterior, this one in nasoorbital ethmoid fracture, NUE fractures is common. And 3D CT scan, the importance is that we can plan the surgery we have, and there are newer method the maxillofacial surgeons they do, we have not done. They can make a artificial prosthesis of the skull according to the fracture, and you can mold a plate according to the this one, the facial skeleton structures, which is different to depending upon the race and everything. So these are the advantages of the 3D CT scanning.
Have you encountered any anterior artery injury?
We don't know, but there is, if there is a torrential hemorrhage, we have encountered, but it stops after this. Because we have lose one patient, one or two patient with a severe hemorrhage, had head injury also, pupil dilated, but I have been called in the middle of the night. Patient arrived with a severe hemorrhage, it was not stopping. We intubated immediately, and we put post-nasal pack, oropharyngeal pack, nasal pack, and everything still. So we can believe those arteries has been injured. Otherwise, small bleedings that normally stops. The trauma bleedings normally stops after a few years.
Yeah, anterior artery injury, I am not very sure how frequent it is, because if there is anterior artery injury, there should be some orbital or cranial hemorrhage.
Yes,
but with this patient, we have not encountered this orbital or intracranial hemorrhage.
We cannot.
Yeah. So I am not very sure whether it is anterior injury.
Exactly. We cannot localize that time.
Yes.
Because
yes, carry on.
No, I am telling you, anterior artery actually you cannot detect. No, it comes from the orbit and passes to the upper part of the nose, and again enters the cranium, and again comes out. Because you cannot detect how the anterior artery. But if it bleeds also, I think you can easily control anterior artery, except if there may be hematoma in the orbit or eye. If it is bleeding in the eyes.
Also, it will form a hematoma, and bleeding will be subsided.
Then you do it a lateral canthotomy, otherwise no other way.
Yes.
Anjana, go on.
Rest of the thing is all complimentary message for wonderful presentation. I don't see any questions. Fauja Vaidu?
On any incidence of ethmoidal pseudoaneurysm is there? One question from Keshavananda.
Yes.
Yes, last.
Incidence of ethmoidal
Ethmoidal pseudoaneurysm.
Oh, have you got any here? I think he's asking you.
Any incidents?
There are a lot of patients who present with epistaxis, that's pseudoaneurysm or angiomatous like seeing in that area. But pseudoaneurysm, I don't know, I've not seen.
Keshav, you have got experience of this pseudoaneurysm?
Sir,
You can
actually,
ask.
yes, sir. Actually, here in itself in Ayurveda, me and Kostav got one patient. It was a crushed injury of ethmoidal area, the whole ethmoid and the nasal bones were all shattered. So there was also skin loss over there. So we did a glabellar flap, and we put a rib cartilage to support the nasal, to form the nasal bone, because the nasal bone was completely crushed. But later on, he presented after a week with an epistaxis, severe epistaxis. So on endoscopy, nothing was found there. We did one MRI. Later on, it came out to be an anterior ethmoidal aneurysm.
Yeah, interesting.
Which then I went through some literature that I found that in crushed injury of the ethmoidal area, there sometimes there are chances of developing these pseudoaneurysms.
Yeah.
Yes.
Very interesting.
Okay.
So I discussed with our radiologist how to proceed for that. So he suggested that we should go for some glue injection directly into the aneurysm, But what we did was we opened up, we went externally and tried to enter endoscopically, but endoscopically we couldn't reach the aneurysm. It was quite deep inside the orbit. So orbit, sir. So first we tried to go through the endoscopically because through the lamina, but we were not able to reach the aneurysm. So what we did was we went externally, then we clipped the aneurysm.
Yes.
After clipping that aneurysm, also after say around 15 to 20 days, he came back again with epistaxis. Then again we went for an sonography. Dr. Dibya Hazarika was there in Ayursundra. He said that the aneurysm is still there, it's shrunken, but it seemed to be kind of coming from the posterior ethmoidal artery also. So I was quite confused now what to do, how much to do that. So he was then scheduled for glue injection. So that he said that I will go for a ultrasound guided glue injection, fibrin glue into the aneurysm. So in the meantime, when he was prepared for that, I put him on beta blockers. When he came for that procedure, he did the sonography. Then it said that it has gone. There is no
You
aneurysm
are
now.
very correct. Because beta blocker is in aneurysm or very work nicely.
Yes, sir.
Propranolol. We have
Yes,
done very nice decision, Keshav.
Good experience.
Yes, sir.
Good and rare experience, I hope.
Yeah,
Yes,
very
sir.
good experience.
That was the only single experience just I wanted to share.
Yes, yes, very interesting,
Thank you, Keshav.
Yes.
Very
there
good.
was
Thank
a
you.
Thank you.
বিজয় স্ক্রিন শেয়ারটো বন্ধ কৰিব পাৰি নেকি?
Yes.
Vijay, hello.
there was a
Yes, sir.
Yes. So, what are the preoperative clearance should be given to the patients before operations?
So before surgery, most of the patient, if they're associated with head injury, because maxillofacial fractures are attended in two places. One, and the hospital on call. Second, in the OPD. Most of the jaw fractures, they move here and there. We have seen the window shopping. So depending upon the status of the patient, if the patient is in ICU and having a head injury, we need to have a neurosurgical clearance first.
Yes.
Depending upon the status. Number two, we need to talk with the anesthesists. If the anesthesists allow the intervention and what is the prognosis of the patient. Number three, we must have a assessment of the eye assessment and should be documented in the consent form or in the file also, IPD file also. Number four, plastic surgery opinion in cases where we need to have we need, or if the patient party also they're concerned about it. We normally don't avoid anything what if the patient party needs something, like sometimes the patient party need a dental surgeon for these kind of things. We always keep it. Obviously, after surgery, the dental treatment is very, very important. We have seen the final figurement comes after proper dental treatment, because loss of teeth and dental surgeons, they are developed in their department, like ortho dentistry department is there.
Yes,
They
yes,
can
yes,
put
yes.
implant, they can align the teeth, whatever we lose in the is under trauma, they can make it. And very nice. And plastic surgeons also for that.
Sure, there should be as cardiothoracic surgeons as clearance should be there.
If the patient
Yeah.
need for
Usually patients have the chest injury or suppose reflection.
Obviously,
Yeah.
if there is associated, this is the multi-system problem. So if the head injury is there, or if the sometimes we work with the orthopedic surgeons, the patient doesn't have any head injury, doesn't have any chest injury, and having this one. So we normally consult with them, and anesthesists they allow. So depending upon the problem of the patient, we get a clearance from respective surgeons also.
So regarding that, as you have told that, so you are given the posternasal packing. So that is a massive JM complex injury. So how do you, after plating and suppose both mandible, jaw, maxilla, giving the posternasal packing, it is very difficult to take the respirations. So how you can manage this is?
Patient initially, in this kind of patient, when they presented with, we got few cases where there is a severe hemorrhage. In Dibrugarh also, when I was there, the patient has a very severe accident and have a crushed face and the habit of supari and tamul in their throat. They have aspiration. So basically, we don't know the where from the bleeding is coming, but we need to protect the airway first. So we directly go for the intubation and cleaning of those areas, and we wash it out with a cough, and we give a oropharyngeal pack first, and we look into the thing where the epistaxis or posterior nasal bleeding is how much. If you feel like the anterior nasal pack simple marrow seal is working, we can wait and watch. If there is a life-threatening bleeding, normally we don't go for the surgery because the patient status is very, very bad. We have lost a lot of patients like that having a severe head injury. Those patients, they come early, that's why we get these kind of bleedings. Otherwise, if they come delay, we didn't get the patient in the
So as much as we should possible the posterior nasal packing actually.
Yeah, obviously if it is not needed, we don't put, and whenever needed, normally we don't need to require surgery actually.
No, Bijoy has presented the paper of the as a faciomaxillary fracture, because if you take as a faciomaxillary injury, from the neurosurgeon to all surgeon, everything has to be involved in it. As he has told that the airway is the first, the intubation, if failure, tracheostomy. Then you can go for other procedures. Otherwise, this is the first. But therefore,
injury management actually.
Yes.
And Bijay, so in what are the cases you usually you do the submental intubation?
I mentioned, sir, those patients where we think that patient can be extubated, or the patient doesn't require ventilation, patient doesn't have severe head injury, or where we need to do a nasal job also, and we need to have a IMF during surgery, that is must. In those cases, if we think that we can avoid the tracheostomy, it all depends upon the status of the patient. Anesthetists also allow us for the this kind of intubation. In those cases, only we go for the submental intubation.
Yes.
Thank you.
There was a question from S.N. Mukherjee sir, whether it has been taken or not. I'm not sure. Importance of depressed fracture of frontal bone and management.
What bone?
Importance of depressed fracture of frontal bone and its management.
Frontal bone.
Lift up. Depressed fracture of frontal bone.
Actually, in case of frontal bone, I have seen, and as because so frontal neurosurgeons usually they manage this part. Frontal bone.
No, we have managed.
No, frontal bone, not neurosurgeon. ENT surgeon used to manage.
Vijay,
if it is involving anterior table of the frontal bone.
Yes, sir. I agree with you, sir. I agree with you, sir.
Yeah, Vijay, I just want to highlight a little bit about frontal bone fracture.
Yes.
Because most of the frontal bone fracture we usually work out with our neurosurgeon.
Yes, sir.
What happens? That depends on how much fracture fragment is there.
Yes.
That also depends on.
Yes,
If it is more than 2 millimeter or more, or even the frontal bone fracture causes posterior intention also, that then neurosurgeon will have to come and they'll have to do.
Yes.
Because there
Here
are
also,
you have to lift it up. You have to have some form of way to lift it up.
Yes.
Yes.
So here also same is going on actually. In case of frontal bone, neurosurgeons actually manage that.
Neurosurgeon is must actually.
Associated with the nasal bone fracture is there. Usually seen. So that part we manage.
Frontal bone depressed fracture always take an opinion of neurosurgeon. There may be some brain injury. Most of the
You're right, Anjan. You're right, but not in all cases posterior table is involved. Maybe only anterior table is involved.
If the posterior table is involved, then you consult a neurosurgeon. Otherwise, no needed. The Nishit Shah has presented a paper 7 days back.
I have managed with anterior table only involvement.
Yes, correct. Because you can do it now. Actually, anterior part of the frontal bone, you can do externally also. But because of the posterior part, you can manage endoscopy. Very difficult. Nishit Shah recently
Marcelda, what we need to know, you have to make an opening in the frontal bone itself to lift it up.
Yes, correct.
Yes.
Actually, what
Yes.
happened? So, in case of frontal bone, there is breaching of the dura matter sometimes.
No, 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 no.
Dura
No,
matter.
No, no, no.
That much
Anterior
is
No, no.
table,
there.
How
there
can
is no
dura matter
portion of
comes
dura.
here?
No,
And
once dura
Not,
matter
not
is
all
come,
cases.
it's
Not
under
all
the
cases.
purview of the
Not all
neurosurgeon.
cases.
Okay,
Yeah.
can I
Organ
come
sinus
in?
will be
Can I come
approached
in?
by ENT surgeon with endoscopy.
Yes.
Yes.
Yeah, can I come in for a minute? Just a minute.
Not.
Hello.
Yes, go down tail.
Yeah.
Yes.
Yes.
Bottom, yeah.
What I want to just clarify, actually, you are all agreeing on that point. If you have an anterior table frontal fracture, it can be jolly well managed by ENT surgeon.
Yes.
If you
Why
have a
not?
posterior table fracture, then
Yes.
it's better
Ekdom
to have the
correct.
Correct, correct.
neurosurgeon's opinion.
Then
If the
Yes.
anterior table frontal
Theoretically,
bone
yeah.
fracture is
Theoretically
more of a
correct, yes.
cosmetic problem, you can easily correct by giving a brow incision, a modified
Yes,
Lynch cord
yes.
incision, putting in a Freer's
Correct.
elevator and just lifting it up. And it
Supra,
stays in place. You don't even have to
supraciliary
plate it. It
incision.
stays in place.
Yes, yes, very correct.
Very correct.
Yes, yes.
Theoretically it's
Gautam
correct.
da,
Sir, it
Theoretically
is
correct,
just
yeah.
like osteoplastic flap only. We have to elevate it and then put it back.
Put it back.
yeah,
Correct the depression and put it back.
yeah, Sambhuda.
Yes,
Hello.
Sambuddha is great.
Yes,
Sambuddha is
yes.
great.
Yes, Tarman,
No,
it
I
all
have done.
depends
I have
on,
done. That's why I'm
Really,
telling.
really. Now you can, yes.
yeah,
yes.
it all depends on what is the depth of the fracture,
Yes.
without touching the posterior part. If
Yes.
the depth is too much and you don't get space, then it will be difficult because it will require a wider incision and wider opening.
Yes, yes. You are correct.
It's usually done like this. Yeah, just open the fracture fragment, just put a drill, put a screw and lift it up
Yes.
and put another screw.
Yes.
Lift up the fragment with a screw and put another plate. It can be done like this. You don't need to
Yeah,
go underneath the
yeah,
fracture fragments.
yeah. Sometimes it happens, but sometimes it is difficult to lift it up because of impaction.
Yes.
With the permission of the moderator, can I add just one more thing? See, as ENT surgeons, as ENT surgeons, we should be confident enough to give a brow incision, open the frontal, because when you are sometimes caught in a wrong situation while searching for the frontal ostium also, you need to have that confidence to go into the frontal sinus, put some dye so that you can see it in the frontal recess area. And if you have that confidence of opening the frontal sinus, I'm only speaking about an anterior table fracture. I'm not speaking about a very complicated fracture.
Like Gautam, Nishit Shah has told about 7 days back one paper. There is frontal refining also, as you have
Yes, yes.
mentioned.
No, we do the frontal refining because
Yes,
the
no
frontal
problem.
sinus is very deep and you can always verify, or even on a plain X-ray. We do the CT scan anyways nowadays.
Yes, yes.
So you can easily
Because
understand
he
that.
told that it is better to go for external approach. If you cannot approach to the endoscopy from the nose, it's better. And there is no role of neurosurgeon here actually.
In fact, actually, in GNRC, Rupjuti does not participate in the seminars, but he would have clarified because we have done a posterior table fracture with CSF rhinorrhea in a patient. We opened the frontal sinus widely and then repaired the posterior table fracture CSF rhinorrhea. There was no brain prolapse. And that patient is actually a relative of Dhiren Das sir's wife, Kaveri's wife. And that the boy is still doing well, and we didn't have any issues. So it can be done, but only you need to have the confidence of, because frontal sinus is quite deep and you can assess the depth by looking at the CT or looking at the X-ray.
Yes, pre-op assessment is important.
I think we don't have any more questions. So,
Anjana, if Bijay has been praised by many people, you tell the name of the people, Dr. Jaman and everyone is been nicely comment for the Bijay. I have also given a good comment because of his lucid presentation and his interest with the multidisciplinary approach at Siliguri. Without this, our ENT surgeon will be lagging behind. Facial-maxillary surgeon will take upper hand. See, and plastic surgeon. Without the group, it will be difficult. He has made a nice group.
Okay, I'll read it out. Surajit Burman has mentioned, congratulations to Vijay for a very educative presentation. Thanks for your efforts. Devika Borua, a very good presentation. Then Jinan Hussain, excellent presentation. And some in the name of 2020, I don't know who is he. He has mentioned beautiful presentation. And Fukan sir has mentioned very informative and lucid presentation for otolaryngologist. Jaman sir, Vijay, you are doing very good work. Thanks for such, I think yes, thanks for such informative presentation. Again, SB Fukan sir, it's a great endeavor for Vijay to make a team of specialties for deciphering evidence-based treatment at Siliguri. Tapos Das, great work, Vijay, in a field not ventured by many ENT surgeons. Keep it up.
Thank you.
Biswajit, excellent presentation, Vijayda. Great work. Kesavananda, excellent presentation. Gautam Khan, excellent work. Kudu Samit, very good work. Good to see your interest and proactive measures in such injuries. Gautam, I mentioned great interaction. And 2020 is Dr. Sumit Agarwal. He is a maxillofacial surgeon. I think he is working with you.
Yeah, he is presently with me only.
Yeah, okay. So it was a wonderful presentation. Anjan, anything to add?
Yeah, it was a very nice presentation. Dr. Vijay has elaborated everything, and there is good discussion and participation by a lot of people. And it my say is that Dr. Vijay has got a very good team, but everyone may not be too lucky to have such a good team with the physiomaxillary surgeons, plastic surgeon, eye surgeon, and everyone. So it's possible to do by oneself also. Only an ENT surgeon can do, but in a selective cases. It's not that everyone will need to get a plastic surgeon's opinion in all cases. So if we can manage it, we are confident to manage it, we can do the maxillofacial surgery also. So if there is some help with the maxillofacial surgeon and the plastic surgeon, that is good enough. So most of the time, eye opinion is very crucial in some respect. So with
Anjana,
that, yes.
Our guest from Chennai, he has gone out, no?
Yeah, I haven't seen him now. I think he has left already.
Oh, left already. He's very interested.
Video bila on kore dile bhal hoy sobe.
Put your video on.
You want to take a photograph or what?
Yes.
Yes, sir.
But I have not used my perfume.
So it was a by the time you click your put your video on, just I want to summarize it. It was a wonderful presentation by Vijay Bania, and he has agreed to present in a very short period of time, and it's a wonderful presentation, and moreover he has finished it in 25 minutes, and and it is a 1 hour discussion. And I know people like to discuss, clarify many things because we are not, many of us are not doing this kind of work.
Yes,
So
we are
it
very
was,
novice.
so many queries were there. So he have clarified, and moderator also helped a lot in answering our queries. So it was a wonderful presentation, and at one point of time, participants were 40. So we are very lucky that number of participants are increasing, and we want more. A deal mange more. So with that note, I think we can come to a conclusion. We can call it a day. So
But I want to congratulate Anjana. You are successful today. Always 35, 36 participants. Today, Bijoy and Anjan has crossed it to 41.
41.
Yes.
41.
Yes.
That's a very good sign.
Yes, but
Nice
actually I have
presentation,
seen,
Vijay.
that that invitation was in a neurology group or different all India group. I have seen somebody was circulating, and I request all of you to circulate as much as possible.
Yes,
So
yes,
that
that is very important. Yes.
we can get we can incorporate many people. So we tried our best to incorporate postgraduates, but there were some technical issues. So I hope they will join us very soon. So with
And
that note, sir, you, please,
and
sir.
Pradeep has come from Jorhat.
Yes, with a very by the stop the YouTube